All right. Hi, everybody. So this is the last session of the day, and I'm so delighted to moderate this session on climate change and mental health in unhoused populations, specifically out of the cold advocacy actions around warming centers in Toronto. And we have two presenters here today. We have Maggie Hulbert and Talveer Mandur, who are both residents at the University of Toronto. I'm so delighted to be here today and to be able to highlight the work that they've been doing over the last while. So Maggie and Talveer are resident psychiatrists practicing in Toronto, and over the past year have been co-chairs of Health Providers Against Poverty, which is a group of health workers who strive to make healthcare provision equitable for all. I should offer as a disclosure, I've also been part of Health Providers Against Poverty, and so this is work that is, I think, so vital and really, really inspiring to see residents who are both engaged in the heavy work of learning to be psychiatrists and also engaged in community work, really working very authentically with various community partners and bringing that lens to the work they're doing. So with that, over to you.
Hello? Okay, yeah, thank you. Thank you so much, Michaela. I just realized I don't have the thing that clicks my slides forward. Is that what this is? Okay, perfect. Thank you so much. As Michaela mentioned, I'm Dr. Maggie Hulbert. This is my colleague and good friend, Talveer. So what we're going to be doing today is walking you through one of the actions that we took on this past year as co-chairs of Health Providers Against Poverty. We have been very grateful to be working with Michaela for the last, for me, a couple years. She's been an incredible mentor and part of this group for a long time. Essentially, we're a national group of volunteer health provider and social service providers of all disciplines that operate under a pretty broad, like, anti-poverty mandate. We're quite informal. We sort of take on projects as they come up, and we work very closely with community allies, and it's been one of the most rewarding parts of my residency so far. Oh yeah, perfect. Okay, so these are the learning objectives for our slideshow. We probably have about like 30 minutes of content for like sharing, and then we can go into discussions or wrap up early depending on how much people are interested in learning more about this. But essentially for today, we're gonna briefly review some of the literature on climate change and health, and it will be quite brief because there's so much and it's extremely depressing, so we're gonna limit it. We're also going to outline, essentially, take you through our advocacy efforts in warming spaces for Toronto in the past year. And the idea is that we would like for people in this group, if you were interested in carrying out a similar action in your own city, to sort of show you how you could think about doing that and to reflect on how many safe respite spaces are available. So this is a rough outline. I think we kind of just went through that. So starting briefly with climate change and health. This is a growing and sort of urgently developing field in terms of climate change threatening our health. And I think we can all sort of broadly understand, yes, climate change is going to threaten our health, but it's really how urgently and how dire is the situation. There was the screenshot I have here is from a comment in The Lancet from January 2023, which essentially basically said that predictions that it was going to be in the next 50 years that health was going to be significantly impacted by climate change are really shortening that interval to maybe 1 or 2 decades. It's worth a read, although, again, quite depressing. Climate change harms health in all populations, so nobody is immune to that. Obviously, there are some people who are extremely disproportionately affected by climate change, and that is, in a large part, homeless population, racialized populations, indigenous populations. Heat-related illnesses and death are increasing worldwide. And then extreme weather events cause significant amounts of injury. They cause direct injury through like physical trauma, chronic malnutrition because it wipes out large amounts of land that can be used for agriculture. And then there's also increased infectious disease spread. We saw in the pandemic, there's been a lot of commentary on how broad this pandemic was, really related to the increase in temperature around the world and how it just proliferates viruses to spread, and it increases contact between species that have not had contact before. I really liked this review, so I included their diagram. So essentially they talk about what are the ways that climate change impacts mental health. And this is a 2021 review by a psychologist. And there were three ways that they identified that it can impact mental health. One is through geophysical changes associated with changing climate. So through like actual physical changes in like the land and weather. That leads to acute events such as wildfires, extreme weather. That also leads to chronic changes like increases in temperature, droughts, decreased air quality. And then the other effect is that you have this social representation of risk. So all the panic about climate change and how we're all going to die. That increases personal perceptions of risk. That causes a lot of anxiety. Anxiety has, a multitude of adverse health effects and can really contribute to like negative mental health. But then, so I like that sort of like different ways of dividing it up because I think it really helps understand like it is a very like pervasive and like broad way of affecting mental health. I think oftentimes people don't necessarily think beyond climate anxiety when they think about mental health and climate change, but there are actually like lots of, there was one study that actually showed like for every degree of warming in the US and Mexico, there was a proportionate increase in suicide related death. So there is actually like associations with suicide, aggression, increase in hospitalization. So it's mental health and it's physical health. And then specifically related to this conference, so thinking about climate change and homelessness, there's a 2021 scoping review by Sean Kidd and Kwame McKenzie, who are both researchers out of Toronto. They have this diagram that I've included here where they sort of talk about, well, what are the risks associated with climate change for the homeless population? So you have exposure to the weather, increased exposure to volatile weather, changes in water levels, so droughts, floods, rapid disasters. Often homeless population is not given, is not necessarily given priorities when there's like responses needed for rapid disasters. And then you also then have those secondary risks, which involve food and water security, vector-borne diseases or infectious diseases. That contributes to things that can be moderated. So where you are, how much exposure you're going to get, the response planning that goes into it, and then the outcomes that contribute to that. So obviously morbidity, mortality, people dying, people being harmed, those are the significant ones. But essentially overall, it's pretty clear that homeless individuals are like vastly disproportionately exposed to climate change risks, including extreme temperatures, pollution, infectious disease. So it is another growing social justice issue. So all of this is kind of setting sort of some of the background for like part of the actions that we were taking. This was a really significant motivator in regards to our thoughts around needing safe respite or warm spaces. So extreme temperature related injuries. In some of the just like background information. So there was a 2015 Lancet study which showed that most temperature related deaths occurred due to cold weather, so not hot weather. But there's like that was from 2015, and there's actually been increasing papers that have shown that heat-related morbidity, so harm and mortality or death, were expected to increase even more. So I think it's going to start changing. Another really important paper that and like data that informed part of our work was that in 2019, a researcher out of St. Michael's, which is where I think all three of us have worked at various times, 72% of cold weather injuries in Toronto occurred in pretty moderate cold, so greater than -15. And that number is going to become very important because when like somebody's at risk of an injury was a really big part of our action. And I think all of this like background academic data like also informs the clinical work that we all do, which is we see people suffering from cold related injuries. We all work in the emergency, or some of us on HPAP work in the emergency department. Talveer and I both do. And we saw people suffering cold related injuries when it was not that cold. And I've seen people with heat stroke from having to be outside. So oftentimes I think for me, the clinical piece comes first, and then I go back and I look at it, and then you can make a lot of justifications for where you want to direct your advocacy. But I think it's important not to separate the two. I don't need a research paper to tell me that people get hurt from being outside when it's cold, but it helps build your argument. So now we're going to talk a little bit about the housing crisis in Toronto. There's so much that could be said, and I don't think it's necessarily unique to any of the cities that any or towns that people live in here. But I think it's what we know because it's where we've worked. So I'll share that with you. Essentially, so in 1996, and this was definitely not the first time this happened, but there were 3 people, Eugene Upper, Erwin Anderson, and Marcella Alden Kottman, froze to death. They were homeless individuals who were sleeping outside. An inquest was held, And that inquest was demanded by advocates. A street nurse, Kathy Crow, she's quite a legend. She wrote a really great book. She's someone who we've worked with and inspires me for sure. So an inquest was held, and emergency cold weather alerts. So those are alerts that are issued by the city for when it's a threshold temperature, started being sent in 2004. So essentially the city will send out an alert. There's probably something in many cities here, but when it's cold enough, if the alert is sent, then there are emergency warming centers open for people to not get injured from the cold. And that was also co-occurring in response to just an overall lack of shelter spaces, as there has been for quite some time. This also tied into the Out of the Cold program, which is where we got the name for our presentation. The Out of the Cold program is a highly criticized program that has run out of Toronto, isn't currently running now. It's run by faith organizations, so it operates out of churches. I grew up in Toronto, and I remember learning about it in grade school. Essentially, like, it offers informal respite spaces in church basements. It's run entirely by faith organizations. There is some, like, people, I think it's criticized because it is sort of like a charitable donation of a human right and an essential space that the government should really be providing. And it was quite informal, and it was never really something people could depend on. So there was a lack of sort of safety around that. And they shut down in 2020 in response to the pandemic, when there was a lot of changes in the shelter system. And then also, just to give a brief intro around warming centers. So warming centers in Toronto, which were always opened at that threshold of -15 without wind chill, so -20 with wind chill, which is very cold. HPAP, our organization, did a report in 2018, which found essentially like a lot of overcrowding. These were some of the actions that were done before I was part of the group. But there's some of the data on there that people were still denied from the Out of the Cold informal spaces. There was not enough space between sleeping spaces. There weren't showers, so it can't, like, there's certain standards for respite sites, and they didn't have a shower. So even with sort of this ad hoc program, which was already criticized, it wasn't really meeting standards anyways. So then COVID happened in 2020, which is actually when I moved back to Toronto. And there was a lot of changes in the shelter system and respite spaces. So 24-hour respite spaces were converted more to like a walk-in model, and we use the shelter overflow. This is sort of a general trend of there just being like no respite spaces. So like nowhere where people can just spend time during the day, because you're often kicked out of your shelter during the day. Shelter capacity was greatly reduced to keep people safe, like from COVID, which was, I mean, good. People should be able to physical distance. And then they opened shelter hotels, which I think, as Michaela mentioned earlier today, were quite significantly more dignified spaces, private rooms, sometimes with a private bathroom, that you could come and go from. And then Out of the Cold program was halted. And around this time, encampments started developing because people weren't finding spaces that could adequately meet their needs or were safe. So they were developed and then very violently taken down, and are still being taken down, as I'm sure is happening in many cities people here are from. And then there's been ongoing with those changes, still people were dying from cold related injuries. So 39 people died due to the cold from 2016 to 2020. And in 2021, 5 people died who were homeless. They died outside. And one of the actions we did that year was we requested an inquest from the coroner in regards to those deaths, which they actually did get back to us. I was shocked to get that email from the coroner, who said that they would do an inquest, although he has not gotten back to me since then. So we'll see. The inquest can take quite a long time, and we're still emailing him. So this is part of the city's own data. City of Toronto publishes data, so it's good to know. And if you don't know, it'd be good to look and see what data does your city publish on homelessness. Toronto publishes, they used to publish more, they've stopped publishing some. But this was a summary of the number of people who are actively homeless in the last 3 months. And it's just gone up and up and up. In April 2023, there was almost 11,000 people who were homeless. And then co-occurring with that is how many unmatched calls to central intake, which is how you get a shelter bed in Toronto. Oh, sorry. So those are also increasing. And also I have to say, like in reviewing this data, I really don't trust it, which is something else that doing activism work has really led me to believe. I just don't trust anything the city says anymore. Because in October 2022, which is where the red star is, you see there was about 180 unmatched calls per day. After that red star, that's when they started closing all the shelter hotels, thereby taking beds away from the shelter system. And yet somehow all the numbers have come down, which I don't think really parallels the experience that we're seeing with how difficult it is to get somebody into a shelter bed now. So I'm a bit suspect of this data, but this is what they have. So essentially, like what was going into the action we're going to walk you through was this sort of like multifactorial crisis, in that there was a decline in respite spaces over the last several years. Shelter hotels people were being evicted from them with nowhere to go. And also there was quite a bit of burnout in healthcare related to COVID, like resulting in like emergency departments that were quite understaffed. And I think in general, people getting, we started seeing people unable to find shelters in our clinical work around fall 2022 at a pretty drastic rate. And we were hearing from our like friends and colleagues who are activists in the shelter system as frontline shelter workers, that things felt really bad, and it felt really scary of what was going to happen this winter, knowing 5 people had died last winter and nothing had really happened. So we started organizing around fall 2022 around what we were going to do around the warming centers or respite spaces. And these were some of the key questions, and then I'm going to hand it over to my colleague Talveer, that guided our advocacy. Sorry, thank you. It was, so who's deciding that it has to be -15, because that's ridiculous, and also not supported by medical literature. I referenced that paper by Stephen Wang, who said 72%, so most people actually get cold injuries much warmer than -15. So why is it -15? So figuring that question out took a long time, because nobody really knew the answer. Essentially, it's a very convoluted system. And this is, I think, if you're going to start doing something like this in your city, this is a really good place to start, is who decides when you're going to open emergency spaces. Because Toronto, like City Council, actually really couldn't even give us a straight answer. It was Toronto Public Health that declared the cold weather alert. It was the shelter, what does SSHA stand for? Shelter Support and Housing Association? Administration. That uses that cold weather alert to direct the warming centers. But like the Toronto Officer of Health had nothing to do with that. And we were sort of like, it was like, what do you mean you don't know when it's open? So it was sort of like an ambiguous question that was helpful for us to sort of pursue. And then thinking about what are the risks of being in the cold without shelter, we already had a lot of that information. And then what could we do about this now? Because there was an increasing urgency that was happening. So I'm going to hand it over to Talveer. Do you want to click the slides?
I got it. Okay. Can everybody hear me? Yeah. Okay. Yeah, like Maggie said, I think we were starting to notice more and more, like especially I worked at CAMH at the time, which has an emergency sort of department staffed by psychiatrists. It's sort of unique, I think, in the province. And more and more people were coming in, with mental health issues, but really it turned out to be like they needed housing. And I think that became very, very apparent. And oftentimes, whether you kept them overnight and discharged them was entirely dependent on how bad the weather was outside and who your staff was, which I think was really morally distressing for residents, where you're basically telling somebody like, hey, like I know it's cold outside, but like you can't stay here. So SHJN, which is Shelter Housing Justice Network, Kathy Crow works with them, and they're one of the organizations that have been involved in this space for a long time. And they actually published a winter housing plan in 2021. They had published some op-eds in like October, November, around the time when the callers were the highest. And I think part of the reason, like Maggie said, you can't trust the data is because that's only people who actually stick around on the waiting line to be tabulated, right? So a lot of people just hang up, and they also knew that it doesn't help. And I actually live very close to the central intake building, and you could tell like it was, the lineups were long. And I think at a certain point, people just stop trying because they know that they're not going to get anything. So, data misses a lot of things, such as people actually don't bother even calling. So a lot of ad hoc meetings started happening in December with SHJN. We I think HPAP and Shelter Housing Justice Network, we established sort of a working group, had some meetings. And I think Michaela really like facilitated that connection, which was, really great because there is a lot of advocacy organizations in Toronto because it's a big city and oftentimes we replicate work. So you'll get a lot of like duplicate press rallies or, press conferences and stuff like that. So with that, the collaboration was really helpful between those groups. We also collaborated with some other groups such as Progress Toronto, which was sort of not just housing related, but related to other progressive actions in Toronto. We also got in touch with some people from hospitals. So like we said, this was last winter, I think was the first time hospitals have been like because, all hospitals were issuing like bed alerts, like their emergencies are full, they don't have any space. And we worked as residents who work at all hospitals in Toronto and all of them were issuing bed alerts. So hospitals were involved in this as well. And we got connected with hospitals, also city councilors. Toronto had a big turnover of progressive councilors last year. So there was a few progressive councilors and they were invested in this as well. And they had released their own statement. So you could see that there was like people doing some things. So we developed some collaborations, had a lot of meetings to make sure like our messaging was more unified. We were taking more unified actions. I think we started like really full on meeting during Christmas. I remember I was visiting family in Pennsylvania. That's what I remember. And I had the meeting when I was there over the Christmas break. And then we started identifying key targets. So there's the Economic and Community Development Committee, which is the committee that allocates money for things like shelter hotels, because the city has to pay hotels direct like payments, which they accepted during the COVID pandemic because nobody was coming to Toronto to stay in an empty, dead city. So that committee was really helpful. Board of Health, which is the board that actually makes healthcare decisions, and Toronto Public Health is involved in that board, including the chief medical officer, because they issued the emergency cold weather alerts. There were also budget consultations happening at the same time. So in January is when Toronto releases their budget, and everything always comes down to where's the money, because yes, we need more emergency spaces, we need more housing, but if there's no money, then nothing's going to be done. So budget consultations became really important. And then there's obviously following up with the council votes, because each of these committees can pass things, but then the council has to vote. And we had a mayor at the time, and I'll briefly mention what happened there, but Mayor Tory was, more sort of not very keen on this stuff. So there was a lot of resistance, I think, from City Hall in the beginning.
Yeah, definitely. And I will just add, like, I think a common misconception is when we're working with all these different groups that we have like large amounts of people who are involved in this. I will say there's like 5 or 6 or 7 of us. So it is very possible to do it with a small core contingent. We all just like have other names and our other organizations, but it was a small crew.
Yeah. Progress Toronto is 2 people.
2 people.
Shelter
Housing Justice Network, 3 people.
So, and I think that's a good point, Maggie, because I think that was really helpful. So when we, so the first thing we actually did was we actually wrote an open letter, which we got like 2,000 signatures. I think we had 800 healthcare workers, about 1,000 Toronto residents. And that you can see one of our colleagues who's actually the incoming co-chair along with me for HPAP this year is Paige holding the letter. We actually printed it on from a poster printing service with all the signatures and brought it to City Hall. And that's the Toronto City Hall, looking appropriately drab. It looks like an evil building, really. So that open letter was really, really helpful to kind of build a base. We had our demands there, and we often use that to reference. And those demands came from the winter plan, which Shelter Housing Justice Network had written along with people with lived experience. And we made sure those demands were sort of meeting the community advocates were saying. We did deputations. I think Maggie did a couple. I did a few. During like clinical time. So oftentimes I would be like, doing an academic half day, and then I'd be like logged, because you could do them virtually. So you're just like, they give you like a number, and they only call your name once, and you just have the list. So you kind of have to keep like an ear out, because once you call your name once, they just like move on to the next person. But I think those deputations go on record, and you can always submit like a written letter as well. So we did a lot of deputations. The press conference, we did a press conference all this is happening in like January, like I think 9th, and the Board of Health meetings on the 16th. So we scheduled a press conference with, I think, just 4 people. I rented the speaker myself and drove down there's a parking lot under the City Hall. So that was really helpful. It was, we had somebody from the Interfaith Coalition, but they were very active and they came. We had somebody with lived experience. We had somebody who was a community advocate with SAJN. And, we really asked that Board of Health pass a motion that we need 24/7 warming spaces. So we removed the threshold, and we really used that study, the 72% that injuries happen in about what they say moderate cold, which I think, being from India, -5 is still pretty cold to me, but that is the moderate cold. So that most injuries were happening there. So we were really advocating that that threshold did not make any sense. So we did. So, after that, Board of Health actually did pass a motion, and the vote was going to happen on February 8th by City Hall, and Mayor Tory was still in power. So we planned a rally, and this rally was actually much bigger than the press conference. We had a big collaboration actually between HPAP, SAJN, the Interfaith Coalition, Progress Toronto, I think Toronto Drop-In Network as well. So a lot of groups. We had a massive banner. One of these community artists just offered to make a banner, which I think was incredibly powerful banner. And we had a flower vigil for people who had died last year. And we strategically had the interfaith people holding the banner with their collars and everything. So, again, to protect, from police response, if that were to happen. I am aware that I look like this, and I'm probably gonna, I'll be the first to get arrested if that were the case. So I'm always afraid to, hold a banner maybe. So I think it's really helpful when you have people who have maybe different positionality to offer to do that. The city rejects the motion at this point, that they don't want to declare an emergency, citing that we don't really, what's the point of declaring an emergency? Because that's not going to change anything. We don't have any solutions. So that's like saying, I don't want to say this person's having a code blue because I don't know how to do CPR, and it'll make me look bad. So, and there's a lot of, we sort of started targeting key counselors who voted no. So very strict, there's a few counselors who are more like center, and they can be convinced either way. And so we started asking our friends and colleagues, just texting them and being like, hey, can you, you're in there writing, can you please use your voice to, ask that counselor, why did they vote no against this a motion that wasn't asking for much here. The budget meeting happens. We actually had I forgot to write here, we actually had a meeting with Mayor Tory after the rally. Yeah, I totally forgot. So we sent somebody who wasn't at the rally, which was not, I was at the rally, so I did not go. And one of our members was able to meet with Mayor Tory. And I think there was some maybe okay, we'll allow something to happen. So the budget meeting, which interestingly was, most of the budget had already been decided. So they had 9 hours to decide $8 million or so, and Toronto budget is $16 billion. So most of the budget was not discussed at this meeting. The city does actually allocate $800,000 for one 24/7 warming center, because they cite that it costs $400,000 for one warming center per month. I think
which everyone was like, what on earth are you talking about? That's so much money. Anyways, but this was a win. Yeah. It was a bit of a win.
Yeah, for sure. And then Mayor Tory also resigns at the end of this meeting, which
a lot of emotions that day.
Yeah, he had brought a letter with him, and I was able to go to that meeting, and that meeting was quite, I think they had kicked out community members for speaking up, and because people had a lot of emotions, because the budget and the police service had gotten an increase from about a $68 million increase in their budget. Their budget is about $1 billion. And we really only got $800,000. So that's not a lot of money, but we did get one warming center open. But then there was no official announcement made for the 24/7 respite center. A month out, we're still not getting an official announcement, but I live very close to Metro Hall. I live very downtown. That's the issue. But it is being used informally. City sort of tells people that it's open, but not everyone. I actually managed to send a patient there when I was on an outreach rotation. We held a phones app about a month out. We actually emailed all the people who had signed the open letter, which was 2,000 emails without MailChimp. That was a lot of work. And it was poorly attended. And we'll talk about that at the end. City does announce the Metro Hall as the official center a month after, and then it's shut. So it ran from February 15 to April 15. So, but dates at 2 months, it ran for 2 months. And then I think after that shutdown, we started transitioning more into what's going to happen as we're moving into spring and the next year. So the general consensus in the coalition is really to ask for 24/7 respite sites, because we realize, like Maggie pointed, heat has a real issue, and maybe people don't die of heat stroke as overtly, but we know it has impact on people's health, which might it might reduce their quality of life. It also affects other illnesses that they have. And I think there was a recent report from BC when the heat dome had happened. I think the highest risk of dying was if you had schizophrenia. So clearly we know that's coming, that risk is coming in the summer, and winters as well happening as well. So there was another rally in front of the economic committee meeting after Mayor Tory had left. And there's a real shift, I think, in City Hall and how willing they are to work with us. And we went to the rally.
Positive shift.
A positive shift. Yeah. So we went to that rally. We did deputations, and the committee actually recommended the city council declare it an emergency, and they prioritize 24-hour respite spaces. These are the things we had asked for 3 months earlier, and we had gotten a no. And the same committee with the same members was now saying yes. And I think that's because we had done so much work, like so many community groups and these are. I'm pointing out the rallies that we helped organize, but there were like rallies by Interfaith Group on their own. We had a rally by Progress Toronto Drop-In Network had done a rally. So there's a lot of work happening in the community, I think, to really put pressure and make the councillors know that this is something that matters. And the city council passes the motion on May 12th. And so that just happened recently. Majority of the councillors passed it. So this is going to be, I think this was one of our goals. So we did accomplish that. We'll share some of the lessons learned, I think, in this.
And I think just to sort of reiterate, Talveer talked about how like there were community groups asking for this, and like by no means are we like cannot take a lot of credit for this. Like I think a lot of the actions in the last few months we were very involved in, but like there's so much history of groups rallying for this, people with lived experience, people like homeless people who have been asking for these things. So I think it's important just to say, like, we really felt like we were collaborating, but we were by no means like the people driving this. Like, I think it's important to just recognize these were asks for many years.
Yeah. Nothing. I mean, if you read the things, everything we have said had been said before.
Yeah.
I think one of the things that felt different this year was, like head of the St. Mike's emergency department was going in person to depute at City Hall. Dr. Huang, who wrote the paper, actually went to City Hall to talk about that paper, right? So there was like, I think, and unfortunately, I think when you go in with a credential, your voice is more, it's like, oh, there's an expert here to talk, as if I've ever lived outside on the cold. I don't like the cold. I don't like being out there, So it's like, but they assume that you have expertise, and in some ways that is something worth reflecting on. That that is something we use, because it does mean that when they're throwing around their credentials and their official status, it is something we can use to sort of add our support to the voices that are already speaking. So I think some of the lessons was, finding allies, counselors, elected officials with shared goals. That was really helpful. Those counselors really helped drive, like the ECDC meeting that I mentioned, the last one. The counselor came up and said, there may be some movement. So I changed my deputation a little bit to like remove any mentions of temperature thresholds to just make it about, because we knew there was something was going to happen. They had really helped connect all of us. People with lived experience, I think that's always as people have mentioned earlier today, it does give you solutions that are more rooted in
Reality.
Yeah, and practical solutions, rather than thinking what we need is, more like shelters, but what people wanted was more shelter hotels, right? Because that is more dignified for them, and that's something they actually qualitatively like more. Relying on institutional knowledge, like Maggie said, like Kathy Crow has been doing this for 20, 30 years. So it's really helpful to know, she knew which counselor was going to vote this way, where you could go, have some movement. I think having consistent messaging was really helpful. We had a lot of sharing information with community groups, a lot of email threads and meetings, and those were really helpful, developing talking points so that if somebody did a media interview, they knew they could reference a document. Having a lot of teamwork, like tagging in for media interviews. We did a lot of op-eds with different people. If somebody can go to a meeting, they can go. And Maggie and I are both residents, so we have clinical work as well. And I was more flexible in the January and February, so I went more to those meetings. And Maggie has more flexibility later. I think media attention, it was really important. It really helped make it look bigger, help make us look bigger than we actually were, I guess, in numbers. Like the press conference, if you crop the press conference, 4 people actually looks pretty, if you put 4 mics in front, it looks pretty official. And I think municipal politics matter. That was the big lesson for me, that 23% of people voted in Mayor Tory's election. And, he gets to decide a $16 billion budget. So I think the politics matter for sure at a city level. What worked well, I think open letter was really helpful. That really helped us gather traction. And oftentimes healthcare providers are, they are busy and they have clinical work. But they were able to lend their support through, signing the letter and supporting the claims. And I think it looks, it is a number that we can use in all our deputations, and, saying that there is a broad community support, that this isn't just like 2 people showing up here. I think showing up was probably the most important thing that worked well, like attending in-person events, doing deputations, which are part of the official record, even though we feel like those words are already being said. I think it is helpful to add your voice along with the others. And like I had mentioned before, using your credentials, like, for better or worse, like I would say worse, that are, the MD credentials, they give more credibility, but we can use that. Getting media coverage, letting them know, doing a press release ahead of time, having sympathetic, we found it really good. Like if you have like progressive, there was a TikTok, I think, based like journalist group, and they were really helpful and kind in their portrayal of us. And I think that was really helpful. Collaborating with long-term activists who know a lot of institutional knowledge, so you're not reinventing the wheel. And planning in advance, like identify who's going to be available, so you're not like playing catch up or wondering, having issues with capacity. So knowing like who's going to be available for what period of time. What didn't work, I think the phones app had poor attendance.
Very poor.
Yeah, it was not good. But I think the biggest thing about the phones app is that it was asking people for more than perhaps what they can give. Signing an open letter is easy. Going to a phones app, like you have to actually call somebody or send an email. Maybe it's a little bit more involved. And also it was, I think we did it in March. Maybe people felt more burnt out by the ongoing actions that we were doing, but that's something to consider next time. I think also framing it as a cold weather issue. Part of the reason we did it is because we felt it was really urgent to like really push for that, because we felt like, again, we were seeing people clinically who were like coming in asking to be, staying for respite, and we couldn't accommodate them. Or the hospitals wouldn't. And but the reality is that emergency has gone, that winter has gone, but the reality is summer's still here and the next winter is still here. So we really needed to focus on the respite sites, or the language of respite centers instead of warming centers. And then we'll finish off with like what's coming next. There's going to be supposedly a table being convened this summer to have like community input, and we're going to try our best to get involved with that table. I think continue the collaboration between different advocacy groups. Like I said, there's a lot of advocacy groups in Toronto saying similar things from different perspectives. So it's really helpful to have consistent messaging, having them all like get together, maybe host an in-person events to build more of that collaboration. And then continuing advocating for respite sites. Like the city has passed the motion now just recently. So we're going to, try our best to hold them accountable, that they've passed a motion. But I think the fact that they declared it an emergency is really helpful, because other cities had already done it, like Ottawa. I'm not sure about Ottawa, but I know Hamilton had done it. And yeah, that's it. Thank you for listening. Sorry, we went a little bit longer than we expected to.
And I'll just say, if you're interested in joining us, we have open meetings on the first Wednesday of every month. They're via Zoom. We have people joining in from other cities. Everybody here is welcome. They're very informal. That's everything.
Yeah.
All right. Well, thank you so much for both the work and also for presenting it so clearly, and all of the like really practical pieces that you outlined. We have time for some questions. So any questions so far? Yes.
So good to hear this as an excellent example of residents advocacy. So I'm actually going to wear my chair hat, the chair of the department hat. One of the ways in which I want to shift the department in Ottawa is to get much more involved in being good at influencing policy, because we live in Ottawa. Yeah. Everybody you bump into is a policy advisor or a policy maker of some sort here. And lobbying is a skill that can be taught, and it's maybe something that we might end up teaching in the residency program. But I suppose the question is, did any of this count towards your training?
No.
If not, why not?
Like formally, no. I mean, some of it I will not put on my CV at all because I don't need my program knowing what I'm doing with my time. Yeah, I mean, I think it's nice to not have it count towards my program in some ways, because I like that I can have my own identity and be separate from my institution, and that's important to me. I think I wish there was some recognition, but I think there will always be challenges if you're integrating with a university that has rules of conduct and structure and what you're allowed to say and what you're not allowed to say. Like, it's hard for me to envision like a full integration. I think Michaela has done a really amazing job at working on integrating parts of it into our curriculum to get people more involved. But I think there does need to be some separation by default. That's my perspective. What about you?
Yeah, I mean, I feel like I'm always very visible. Like every time I show up to a rally, I'm the only like psychiatry resident who wears a turban, and I'm the, so when I show up, like you can always tell me. My family always recognize me in the news. So like, what are you doing there? Like, and they live in Kitchener. They're like, were you on CP24? And I'm like, yes, I was. So in some ways, like the visibility isn't really like it's always there. But we're not doing anything illegal. Like I always think about it that
Definitely.
way, right? Like,
yes,
we
check.
Yeah, we didn't really, we and our words were very measured, and I think we spoke with passion and coming from a space of like frustration and anger. But at no point, we say all the right words. We we respect the counselor's position, and there's no swear words in any of our deputations. You can look. What happens in here doesn't need to come out, I guess. But the other thing is, it is really hard when it's not counted. Like, for example, if you want to do clinicians, like we have protected time in our program to become a clinician scholar for like, let's say, and you can do like a QI project, or you can do like a more of a extended research project, but it's hard to integrate like advocacy in that protected half day, because you need like research objectives, and you need like a supervisor who has like a research program. So it's really hard to get that protected time. Like the reason I was able to do a lot of the stuff in January, February is because I was on a very flexible rotation. I was on ACT. So I could work and I could do this in the morning if I needed to go to the city hall, and then just work in the evening, for example, or see all my patients on a Friday if I had to do that. So I think being on that flexible rotation helped, but it would be nice to have it like a half day protected time. And I think the trainings would be like, how to lobby, like a formal teaching program would be really helpful, because a lot of the work, the way we learn this is by just like trial and error and learning from community advocates. Like they've been doing this for a long time. Like last year I spoke at the ODSP Action Rally, and they're very welcoming, and they tell you like, this is how you can, these are like, it will give you some time, and like there's no fear here. And I think those spaces are so welcoming. In some ways, like more so than academia, I feel like, where being critical can be sort of seen as like a threat, or like you're shut down, and it's kind of nice to be in those spaces. So it would be nice to have more protected time. If you want to, I think, advocate for that, that'd be great.
The counter argument to not having it in the training schemes, if you include it, then it's systematic. People then do it, and you can lobby for training for it, and it becomes part of training. I mean, doesn't CanMeds have something like patient advocacy in it, something like that?
Yeah. Miguel, maybe you want to. No, go ahead. Yeah.
I was just going to add a couple of points. One is just to say that it's like, I think it takes courage to do this work in residency, because you are still in a training program. You still have to, you're thinking about getting jobs. You're thinking about all of these next steps and passing rotations. And so I don't know, I just feel really proud of the work you've done. And I think it's really, really incredible. And I really, I've done some of this work throughout my residency, and I've continued to do so as a staff psychiatrist, and have always have tried to find different ways to bridge the academic world and the community-based world, because they are often quite separated. But presenting about advocacy, presenting about challenging the system in conferences, I think, is one way to do it. Bringing things into the education system is another. Like, I've been thinking for years, could we have an advocacy track or public policy track in some way within residency? Maybe one day, when you graduate, we can do it together. But I think I just wanted to speak really briefly about the question of legality, because you were saying that nothing that happened here was illegal. I think there is also a role for civil disobedience within medicine, within healthcare. And I think there's lots of examples in different places. And civil disobedience, I think, is often done by people who have less power, to take power, to create power. And I think there's work that we can do as health providers to engage in civil disobedience. And that can look in a lot of different ways. Like way back in the G20, when that was in Toronto, I was involved as a street medic. And that was sort of my dilemma of sort of thinking through the legality of what I was doing and trying to figure that out. Holding demonstrations when there's a public health emergency. I think that was some of the work that Health Providers Against Poverty and other groups were doing as well, when we actually were not supposed to be doing that. There's endless examples, right, of how you can challenge power in really direct ways. And institutions will not always like it, but that doesn't mean it's wrong. Laws are created. And so I just wanted to add that piece. It's complicated, but I think important to think through as well.
Yeah, good point.
Thank you. That was absolutely fantastic. And thanks. I'd love to become a resident doctor again for many reasons. One of the ways you can bring this sort of work actually into curriculum is training and teaching people about the instruments of policy. So what are the things that actually open the doors with policy? And all too often, we're trying to shift policy, but using the wrong tools. You're trying to use a screwdriver where a spanner would work with a policy. And I think building into curriculum broadly, understanding what the instruments of or levers of policy are, and when do you turn up in what space with what tool, can go a long way. That's great advocacy work. Linking with the climate one I found really useful, particularly for heat, is using pavement temperature. And on a day that feels like a beautiful warm day, 35 degrees, pavement temperature can hit 55. And I've started quoting pavement temperature. And in Kingston, some of those affiliated with your group, they were doing a fair bit of powerful advocacy. Their weapon sounds wrong. Their instrument of choice was chalk. Just writing the pavement temperature on the pavement on a high street, 55 degrees, 52 degrees, and so on. And that really caused a stir. Wow, you mean people are lying down on this? They're roasting. But fantastic presentation. Bravo, bravo. Thank you. Bravo, brava. Before I get into trouble.
Any other questions or?
Do you want to use this one?
So I guess my question is kind of like, how do we future-proof this? Like, it feels like so much of our advocacy is actually playing catch up with where things should already be. So when we're advocating, how do we actually advocate for more than we need so that we're prepared for what's to come with climate change, what's to come with the housing crisis and increasing rates of poverty, so that, when we get what we want, we aren't then playing catch up again for the next 10 or 20 years?
Great question.
Yeah, I think that's a.
I don't know. You go first.
Okay. I think it's so relevant because warming centers, like the respite centers existed, right? Like there's like warming center standards, there's respite center standards before COVID. And like when they all got shut down, we're like now trying to reopen them, things that are already on city's website. Like the city was still listing 24/7 drop-in sites, 7 of them, which don't exist. They're not 24/7 drop-in sites. And I'm like, your website hasn't been updated in like 3 years. And when you're like on the ground, and what's really hard is when you need to actually send a patient somewhere, and that center is like, they're like, yeah, we don't operate as a 24/7 respite site. They existed, and there's been an ebb and flow. Like again, I think Kathy Crow writes a lot about this in her, like on her Rabble blog. Like, they got a lot of stuff with the inquest in 1996, and that's when Jack Layton was a city councillor in Toronto. That's how old the issue is, right? So, and it's been like, oh, they get something and then it's been taken away, and then they get something and it gets taken away. And then what I find really hard is that I guess the point is like you always have to be fighting for the issue, like be on the lookout, and like having that institutional knowledge. Like, you know, for example, like SAJN and Kathy Crow has been like talking about it for a long time. Like Michaela knows a lot of the past, like she was involved in the 2018 report, and I think we're relying on those like institutional like knowledge. But at the end of it, you know, it is nice to have like capacity is always an issue. Like the hard part is always capacity, and I think getting like new trainees involved, that's why it helps, because you have like the fresh sort of approach. You may have like more time, you know, like unlike staff who has maybe more responsibilities. Like, you know, being a resident is really hard, but like in some ways, like our time is more predictable than a staff, for example. And I think getting those people involved is really helpful. Like in HPAP, that's been one of our goals, is getting like younger clinicians more involved and to get their like fresh perspective and like transfer that institutional knowledge. So because you're right, like this can change in 3 years. We could be asking for the same thing again. It's possible. Hopefully not. Hopefully we're building on it.
Yeah, I mean, I think my answer is that there is no future proofing, because city council will never give you more than what the bare minimum is, because, and like, you know, you can try. And I think there are people who work much harder than we do at this. Like there's lots of active activists who like, this is like the majority of how they spend their time. And it's incredible to me. And it's astounding, because I'm like, how do you have this energy? But it's because you know, it's their friends, it's their life, it's their loved ones. And I think that sort of helps us keep moving forward. But I think ultimately I can't imagine our city council ever being like, you know what, maybe we should raise the threshold just to -5 because it's going to keep getting colder. No, that's not going to happen. So I think you just give up on that idea, and then you just expect every November, what are we doing? Like, because it's going to get colder or it's going to get warmer, or like what's happening. So being prepared, and then, yeah, recruiting people to be there with you.
Other questions? I have a question. I'm wondering, I mean, this wasn't exactly your presentation, but I think like there are a lot of people here who work doing street outreach, or who are working with their community members on the streets. I'm wondering if there's any really practical suggestions you have from your ACT work experiences or other experiences that you've had, what you would advise, like if it's a heat alert situation or if it's a cold alert situation, to try to support people to stay alive.
Yeah, I think it's a like a very, what really when I was doing ACT, like what really hit me how real this was is when I had a patient who was living in community housing, like quote unquote stable housing, being assaulted like multiple times, and we couldn't find any space. And that continuous warming center that we had gotten was the warming center I was able to send him in. So I think like one of the things that really helped was like having a practical like bird's eye view of all the services available in the city, like actually knowing like which, and I think oftentimes as like psychiatrists, like, I mean, for me, it's often like meds and, you know, some therapy, like we train, but it's like the social stuff is like, oh, that's for social work. But I think all clinicians have to sort of know what the like stuff is available in their local city, who's actually has like more likely to give space. And I think like maybe doing some, it'd be nice if it was part of the curriculum, but I think like reading around on what's actually available and having a compilation of resources. In terms of like other practical stuff, like I think in the heat, like, you know, some practical things like checking up on people, making sure that they are not like, that they're actually drinking water, like, you know, practical advice like that. I think on ACT was like, we did a lot of check-ins around people who in the winter, like making sure they were okay, making sure that they had a jacket, or like trying to hustle to find them a jacket. So I think like there's a lot of practical things that trainees pretty much in any discipline, or even like anybody in any discipline, should be aware of, especially if we do street outreach, because I feel like you're never just like the psychiatrist like prescribing medications in street outreach. Like you're always going to be trying to do more. Yeah.
Yeah, I think that's a very good question. And I'm trying to think of something practical to say. I think so much of the time, like I think for me, one of the things that was helpful was realizing that many more cold injuries happen when it's a lot warmer than you think it is. So that was helpful for me, especially like if you're seeing people and you're wearing really warm clothing, like knowing that if that's not what somebody's wearing, it feels very different. But then also like, maybe this is a bit less practical, but like the data says one thing. Sure, it says like cold injuries cause more harm than heat injuries, but like in a sense that's kind of fucked up because like it's people are suffering. Like if there's extreme weather, we all know how miserable we are when it's hot. We all know how miserable we are when it's cold. Like people who are homeless don't experience a different like type of feeling. So data says one thing, but like trust, like if somebody is really suffering, like you can advocate for them even if they don't have frostbite yet, right? Like let's not let it get that far. So I think understanding the issue more for me made me just take extreme weather quite as more of an emergency than I did before. Like, people don't have to get to that point of being really injured or hurt or die. Like we need to advocate a lot sooner than that. And so that was sort of like a big takeaway for me was like when it's really hot and I'm on my bike and I'm sweating, like how are my patients doing? Probably like a lot worse. So that was, I think, my personal takeaway.
Okay, can I add one more thing from one of the things that I'll sometimes do is write letters for people to get air conditioners. So anybody who's on OW or ODSP, I've had, I will look at what the cost of the more expensive air conditioners are, and people will get the money. And so like if a lot of the housing that people live in is so hot and people can, obviously be uncomfortable, as you pointed out, but also die in those situations. And I think, we're seeing a heat wave in BC right now. It's May. Like, what are we going to see in June, July, and August? I don't know.
Yeah, it's a good one.
Any other questions or any other experiences from any? Oh yeah, please go ahead.
Conversations asking City Council to fund seasonal drop-in low barrier spaces. And one of the fears that's part of the narrative is if we fund spaces like this, then the bylaw we passed 5 years ago, making it illegal to sleep in parks, will be like, we will act on it pretty ruthlessly. So if we're putting money into drop-in centers, then we will not allow anyone to sleep outside, even though the number of spaces in a drop-in center by no means is the number of people who are outside.
Where do you live?
In Peterborough.
Peterborough, okay. Just like to keep track.
And then as an added layer to that, advocacy is really hard for community organizations that receive municipal funds. Because the threat is if you advocate for encampments to be allowed, then we will pull the funding. So I'm just curious if you navigate any of that, any advice for us?
Oh, well, it's amazing that you guys are still pushing. I think that's so incredible. I think like in regards to the funding piece, that's part of why like HPAP is great, because like healthcare providers are like, we are affiliated, but a lot of the time you're not attached and you don't depend on an organization. So we collect donations from our members. So we kind of have a little, very small like pot of money that we can use for actions. So it is very helpful that we stay separated. So I can imagine that being very challenging. I think like that conflict is really real. And I know a lot of our colleagues who work like in the shelters feel that way. Like they don't want their names or their faces like that up front. I think in regards to that, like if we fund respite centers, then we're going to have to force everyone out of encampments. Like that's just such an obvious threat, right? Like, and that doesn't make a lot of sense to me. And usually when we come up in those situations where it's just like, that makes no sense. Like we try to, for better or for worse, there's like critics of this, but we try to go back to the health related data because I think you can kind of bamboozle some city councilors with it because they don't totally know what you're talking about, but they think you sound smart. And then two, like, I think we did some advocacy around encampments, and we have like kind of some go-to like research papers around like people who are saying like these are the harms of encampment evictions. Lots of people have spoken out about it. I'm happy to share any of those resources because we can kind of say like, well, here's all these health organizations that have said that eviction of encampments there's actually just a recent really big medical paper that talked about the harms of encampment evictions and like downstream harms. So you can kind of go back to that and say, well, that's really not evidence-based. That might not work, but for us, like that's been a useful negotiating tactic. And I think that was what was helpful with getting the ask of the warming centers was, well, there's this paper based in Toronto that shows that's not when people get hurt. So why are you doing it that way? So that's kind of been an approach we've taken, and that's our background. I think you can criticize if it needs to be medicalized. It doesn't. It's a human right, and that should be enough. Like, it's dignity. But I think having a novel tactic can be helpful.
In addition, like what Maggie said, like I think one of the things we've been asking about is we were working on not getting like stopping evictions as well. And I did get in touch with, I'm from Kitchener as well, and the legal case out of Kitchener. So in practically speaking, if you want to get in touch with I can put you in touch with the legal clinic there. I actually spoke to one of who happened to be like an old friend. And they did have people speaking out from in the court case, but the city thought, like Waterloo thought that they could, or Kitchener, I think they thought they could just like evict people legally, but then they filed a challenge, and the judge actually agreed with the workers who had like done a lot of interviews with and a lot of like relationship building with people who were living in the encampment, and now it's like they passed a motion that, or the case decided that you can't evict if there's no shelter spaces. So practically speaking, I think that like tactic can be really helpful, and like what they actually did. So I'll give you my contact if you want to get in touch with them. And I think sometimes that actually helps to not be affiliated with like as a doctor, like we're like a private, like you're sort of self-employed, especially once you graduate. But even like now, my funding comes from Ministry of Health, not from the city. So I kind of felt like, it was okay for me to like say more things or like put my face out there, because I know that the city doesn't really pay my funding. So I think like that sort of just relates to why it's helpful to have people in, allies in different fields. But yeah, practically speaking, I can put you in touch with that legal clinic, but I think the legal case might be helpful as well. And that is something we cited to the city as well. And then the city is they've said unofficially that they're not clearing, but they are still sort of like low level clearing. They're just not doing what they did in Trinity Bellwoods. And I think the ombudsman report came out of that eviction and how like violent and like, unethical that was as well. So that's something you can reference. But yeah, it's really hard.
Yeah, it is. So good for you.
I'm just curious, with a show of hands, who lives in a city where there have been police encampment clearings? I mean, this is like, it's just horrifying, right? Like this people are being taken from places where they're living. I mean, we know it's happening in BC. We know it's happening in Ontario. Sounds like it's happening pretty much everywhere. And I think that the only way that I can continue doing this work, working with people who are unhoused, is by also looking at the systemic things and trying to advocate. And I think that's why Health Providers Against Poverty has been like such a lifeline for me, to be able to try to address like the policy issues, the systemic issues, and to do that in community with other people who are fighting for the same thing. Because we know that these systemic root causes, like that's what kills people. And I mean, I don't think it's getting better, right? Who here, again, just show of hands, has had similar type issues with lack of access to warm spaces in the wintertime in their city? And what about cool spaces in the summertime? So I mean, this sounds like it cuts across, and I think it's really powerful to be able to connect and to share resources. And I think this presentation was so fantastic because it sort of broke down the pieces from one campaign, right? This can look really different in different places, but thinking really strategically about how to work together to share messaging, to share resources, to share tactics, to share ways to speak to city councils or sort of wherever the money comes from and wherever the decisions are being made. So hopefully we can continue having those discussions.
Yeah, I welcome, if you have any questions, I welcome anybody to chat. I'm on Twitter, also Maggie Hulbert, or I can give you my email. Like, very happy to share any of the slide materials or just answer any questions about this. And thank you all so much.
Yeah.
Any last questions? We're pretty much at time. I have a few important things to say. Thank you everyone for coming to day one of the conference. The next thing will be at at the Heart and Crown in the Byward Market. The address is in the event program, but if anybody needs to know where it is there anybody who should they ask? Any of the conference planners? There we go. And tomorrow the day will start at 8:30 in the morning with breakfast and registration. So thank you so much. It was really wonderful discussion and appreciate the work you all do.